peripheral vascular disease, when it comes to peripheral vascular disease and disease of the major arteries, the number one pathology is really atherosclerosis, as you may know. And you keep this in your mind, 60%, I'm sorry, if you have coronary artery disease, likelihood of having PVD is about 30%. If you have PVD, the likelihood of having CAD is about 70%, right? So that gives you an idea that the coronary arteries are more prone to have atherosclerosis because of the location and all of that. But in general, if you're gonna talk about peripheral vascular disease and the disease of the major arteries, we can talk about divide them about aorta, disease of the aorta, and we can talk about carotid arteries. We can talk a little bit about renal arteries and arteries of the legs. What we call basically, the in general, peripheral vascular disease in general is really disease of the lower extremity arteries, plus the pelvic arteries. So diseases of the aorta, most of the time, the diseases of the aorta are because of atherosclerotic process, except certain diseases such as Marfan syndrome, when you have issues with the aorta structure, or sometimes with bicuspid aortic valve when you have also aortopathy. But what you have to remember, numbers which are aortic aneurysm numbers, the ascending aorta 5.5 centimeter or more, descending aorta in the thoracic area 6 centimeters, and the abdominal aorta used to be 5 centimeters, now 5.5. So remember, 5, 4.5, 6, and 5.5 AAA. Anything above these numbers, you have to consider intervention because the risk of aneurysm rupture is extremely high in these patients. There's another number you need to remember, which is 1 centimeter per year. If you have increase in the size 1 centimeter per year, in that case, you have to rush your patient for surgical consultation. Okay. How much is that important factor for the for patients in the nursing homes? Is really, I think probably your patients are not. Most of the time, these kind of diseases happen in people a little bit younger and a little bit healthier when you have to worry about it. If you have somebody with ascending aortic aneurysm, 6 centimeters, 90 years of age, mortality is going to be extremely high if you're going to try to repair it, right? Now, as dissections and stuff like that, it's really well known to everybody. Type A dissection, the Stanford classification, type A dissection, anything involving the ascending aorta, surgery is a key. Remember this number, that your mortality rate increases 1% every hour after dissection. So it's about 48% after 48 hours. What does that mean? When you have type A dissection, any dissection involving the ascending aorta, you really need to rush your patient to surgery. I can tell you that I lost my cousin, 34 years old, type A dissection. No surgical intervention was done. When they tried to suture the aorta, 3 days later, tissue was just like melted meat. So died on the table. So remember that ascending aorta, you have to dissection. When you have any doubt about it, you have to send the patient to emergent surgery. Okay. And this is probably the number one surgical emergency for vascular and cardiovascular surgery, anything, outside the heart perspective. The type B dissection, the dissection involving the descending aorta, thoracic and abdominal, usually medical treatment involving beta blockers and decreasing heart rate, decreasing blood pressure, decrease the shear forces. And when you have involvement of the renal arteries, you have to chat about possible, kind of intervention, because if that can affect the renal arteries, you may lose your kidneys. That's really beyond the scope of some lectures like that. But in general, remember that ascending aorta surgical intervention is needed urgently. Now, when it comes to carotid arteries has, our way of intervening with carotid arteries, has been changing with the change in medical management, right? You know, if you have um, symptomatic stenosis, i.e., you have ipsilateral, um, changes in vision, um, or facial changes, or if you have contralateral lower upper extremity movement weakness, in that case, that's called symptomatic, and these symptoms should happen within 6 months. Any stenosis of that carotid artery above 50% needs to have surgical intervention or stenting. Okay? So 50% with symptoms, and symptoms should be less than 6 months. If somebody tells you, well, I felt I had TIA year ago, that should not apply as symptomatic carotid artery stenosis. So symptomatic should have stroke within the last 6 months. Then intervention of the stenosis above 50% is indicated, right? And the number needed to treat is about like 6 or 7. So, that's pretty dramatic in medicine. So this is why we have to be careful about that. If the stenosis is if the patient is asymptomatic, stenosis above 70%, you can think about it. In other words, you have to think about, is your surgeon is available? Is the surgeon that intervention is going to have carry less than 1% complication risk with stroke and so forth? In other words, it's up to you as a provider to decide if the stenosis above 70%, if you want to send your patient to intervention or not. That's pretty good for us. So if your elderly patient at the nursing home with stenosis about 70%, don't really panic. What you can do, you can maximize medical management. And any kind of vascular disease, medical management is two things: antiplatelet agent and statin therapy. And the statin therapy should be in high intensity statin. High intensity statin, we'll talk about Crestor 40, Lipitor 80. Moderate intensity statin, Lipitor 40, Crestor 20. If you think that your patient might have issues with it, start with like Crestor 20 or Lipitor 40 and up titrate that if you want. Okay. When these trials done in the 90s, we didn't really have that much stronger statin back at that time. So this is why, this is why this is why there was little bit more emphasis on surgical intervention or intervention in general. There is a little bit improved outcome when it comes to endarterectomy versus stenting. Stenting seems to have higher periprocedural complication when it comes to stroke. And the reason is, whoever knows about the intervention, Steve does know stuff like that very well. So you insert a wire and you're going to inflate the balloon and trap the blockage, and all this process, any kind of movement, the only way is going to go to the brain. And this is why complication rate is very high. I sit in the committee for IVRC, which is discussing complications of procedures at Memorial Hospital, and I can tell you, every time we have a stenting in the carotid artery, it should come to because stroke risk is very high. So just keep that in your mind. If you're elderly patient having stenosis above the 70, and you feel that this patient did not have symptoms within the last 6 months, which is not any symptom, amaurosis fogax in the same eye, or facial movement issues, sensation in the same place, or ipsilateral, which is on the other side, upper or lower extremities. That's that happened within the last 6 months that's symptomatic, you have to send your patient for intervention, or you have to justify not sending your patient to intervention. But if you have severe stenosis and patient is asymptomatic, there is a way for you to justify medical management, and that's reasonable. Now, when it comes to the other arteries, such as the upper extremity subclavian arteries, you just remember that if you have patient with history of smoking and peripheral vascular disease, coronary artery disease, sometimes you have to measure blood pressure in both arms because they may have stenosis in one of the arms, and you have to rely on the one with the highest number, obviously. But I wouldn't be very aggressive to send this patient for intervention unless they are extremely symptomatic. When they move their arm, they get dizzy because of the subclavian steal syndrome, or they have a true upper extremity claudication. Otherwise, really don't need to bother, use your statin and aspirin and move on. When it comes to the renal arteries, even actually renal arteries, unless you have worsening kidney function with blood pressure intervention, or you have resistant hypertension, resistant to multiple medications, including diuretic medication, you don't treat.
I was looking for you were in the meeting, so I said, okay, I could talk to you some other time. Here's my concern. We have the backup
Hey, Lisa, can you mute yours?
Can you mute yours, Alicia?
Mute.
Yeah.
Okay.
Just unmute it.
Did I do that?
Just
Oh,
unmute
you can
you.
still hear me? Sorry, guys. Boomer here.
No big deal. Just
Is
remute
it
it.
muted?
Talk now. Say something. Actually, we're fine. We're fine. Go about it. Okay, so
it should be
So sorry.
me, but if we can
just to,
make that connection to the dialysis
Alright,
room, so if the
so,
patient is on, it doesn't get clotted. The risk is they can throw the clot to the patients.
Hey, Alicia,
So if you
do you know how to mute yours?
look at that,
Yeah, I'm trying.
It'll be at the bottom of the screen.
Sorry, guys.
he has to change the dialyzer because the dialyzer clotted. For 8 minutes, nothing he could do. Okay.
Did I do it?
No.
Mhm.
Yeah.
Can you hear me?
Okay.
No?
Okay. Thank you. Okay. Bye-bye.
you do your stuff.
I'll mute it. Okay, I muted her.
Oh. All right. Hey guys, can you hear me? Okay. All right, Shay, you can hear me, Shay, right?
Yes.
All right. So yeah, renal arteries and the stenosis we look for in renal arteries to be effective is about 70% or more. So renal artery intervention, you have a stenosis more than 70%, and you have resistant hypertension to multiple medications, including diuretic, or you have worsening kidney function when you try to control hypertension. In that case, stenting is justifiable. And usually we tell the physicians, they know that they really need to let the stent outside in the aorta because, these restenosis in the ostium is extremely common after stenting. Before I move to the lower extremities, just remember that in peripheral vascular disease interventions, dual antiplatelet therapy is for 1 month only. Even for carotid artery stenting, the clinical trials, CREST-1 trial and others, they did antiplatelet therapy for 1 month only. Why? Because the first month after intervention, when you're going to have most of these complications, beyond that, they are usually bigger arteries, likelihood of restenosis or thrombosis, likelihood of thrombosis is very low. So, aspirin, continuation of aspirin beyond 1 month and statin therapy is going to be the key. For peripheral vascular disease, lower extremities lower extremities, it's really, you have to understand that restenosis in lower extremities is extremely high, especially if your patient continues to have the same bad habits, which is smoking and controlled hypertension and controlled diabetes. All right. So I keep telling everybody that, the only two indications for you to intervene on patients with peripheral vascular disease, lower extremity arterial disease, is if your patient has unhealing wound or disabling symptoms. Because they did clinical trials with the new medications, with the old medications we have, and they found during these clinical trials that, supervised exercise for patients with peripheral vascular disease versus stenting, actually they had the same outcome. Okay, so for your patients, especially in the nursing homes, they have peripheral vascular disease, it's good to know. If they have unhealed wound, in that case, you need to send them for intervention. If they don't have wounds and they're able to walk around and, move the way they move, because most of these patients, they have other disabling factors, like dementia, they have, arthritis, they have, body habitus and so forth. These patients just need to be careful, treat with aspirin and statin therapy and move on. You don't really need to have this, 80% stenosis, 90% stenosis, total occlusion, or whatever occlusion, the peripheral vascular disease, superficial femoral artery, whatever, that you have to send your patient for intervention. These vascular surgeons, intervention cardiologists will like it, but that's really not the standards of care. So you have to be careful about that. So for us, we have a lot to do with medical management nowadays. And if you think that your patient is symptomatic, you can do cilostazol, and the cilostazol 100 milligram twice a day. And as long as your patient doesn't have congestive heart failure, class 3 or 4 heart failure, I think this medication should be reasonable to use. But, again, the key is going to be for you to use, just one second, for you to use this statin therapy and aspirin.
What about the 10 milligrams Xarelto?
Yes. Damn, somebody's reading. Wow. What do you know? If you tell me the name of the trial, you'll get 100
Oh,
bonus.
oh, I don't know. I don't think that one I won't get.
Don't get nothing. It's called Compass trial. You're right about that. Just let me know
Okay.
1 second. No, it's 5 twice a day. It's 2.5 twice a day, right? 2.5 twice a day. So they did the trial. It's called Compass trial. And the Compass trial, so they did trial, which was 2.5 twice a day with along with aspirin versus aspirin alone or aspirin Plavix, and they found actually better outcome when you do the 2.5 twice a day of Xarelto and aspirin. We really don't understand the mechanism, but the data were very solid. The trial was huge, big, multiple, I think more than 20,000 patients. And they found that, if you add the 2.5 twice a day of Xarelto, there's better outcome. And what you have to have is peripheral vascular disease or coronary artery disease, chronic peripheral vascular disease or chronic coronary artery disease, stenting or CABG or whatever. So if you want to use that for your patients, there's actually good outcome. I think the number needed to treat in that trial was about 60 or 66, something like that. So it's not bad to prevent bad outcome. So for your patient, you have to use your clinical judgment. You want to add another burden on the nursing home or another burden on the patient when it comes to high risk of bleeding and so forth. So be it. If you're out of options and the leg is really bad and there's little indication for cyanosis and whatever, decreased discoloration and so forth, you want to use it, do it.
Okay.
But take everything in clinical context. Now, the acute limb ischemia aspect as well. The acute limb ischemia aspect, when you have abrupt, quick stenosis within, symptoms in acutely, and we use acute term when the symptom starts within 2 weeks of you seeing your patient. In that case, actually, you have to assess, and there should be change in color, pallor, or sometimes redness, decreased or diminished pulses. When you have sensory loss is okay. When you start having motor loss, then there's indication that the foot or the lower extremity is actually becoming an issue, and muscles are getting dead. So you have to really send your patient for either stenting or urgent vascular intervention. These patients need to go to the hospital. Heparin needs to be started, and after that, vascular intervention should be done. But for you, is a matter of realizing the issue, and I think sometimes it's really challenging, difficult, but you really don't need to panic if you think that this is really acute limb ischemia. So be it. I mean, there's nothing wrong with making the decision and sending your patient to the emergency room for them to evaluate this patient. Until now, we debate in the emergency room, is it really acute limb ischemia versus chronic, and patient is just having more symptoms because of the chronicity of the issue. But acute limb ischemia, when you have thrombosis, it's about 20%, emboli about 50 to 60% of the time, and combination of both in the rest. So emboli most of the time is coming from either the major arteries, aorta down, or from somebody with atrial fibrillation. So that's another thing. Anything else we have to discuss about it? So we talk.
So in the patient nursing home has a non-healing wound,
Yes,
if we've never diagnosed vascular disease, do we start aspirin and statin
sure,
and do a stepwise therapy?
Sure,
as a relative
sure,
product?
sure, we can do that. That's reasonable. If your patient, there's really, and some of these actually wounds as well is microvascular disease. As you know, the diabetes, uncontrolled diabetes, really doesn't increase the risk of macrovascular disease as much as it does increase the risk of microvascular disease, and what we call endothelial dysfunction. So sometimes, the arteries are really patent, but you have microvascular disease that, deep in the tissue, this kind of blood flow is not really going enough, and this is why you get this kind of issue. Yeah, exactly right. And when they did the advanced and accorded trials in 2008, they found that, even if you drag your A1C below 70, you don't really change the outcome of macrovascular disease, i.e., peripheral vascular disease in the major arteries, or coronary arteries, but you decrease the microvascular. But that's semantics. That's what you have to understand always, that diabetes should be controlled, A1C less than 7%, no matter how you feel about it. Your patient should be on high intensity statin, aspirin when indicated, and so forth. Remember, aspirin there are a couple of clinical trials came in late 2020, and these clinical trials talking about the primary prevention of aspirin, and they found that there's really no indication for aspirin for primary prevention. In other words, if you don't have coronary artery disease, peripheral vascular disease, history of stroke, history of MI, any other indications to use aspirin, you should not use aspirin in your patients. I practiced this way. The only people that I used to use aspirin for primary prevention were females above the age of 60, but turned out to be is also wrong. Actually, you really don't need to use aspirin in your patients. Even in patients with atrial fibrillation, there are no data, or there's no data to support your use of aspirin in in your atrial fibrillation patients, either nothing, chest VAS score 0, or something, chest VAS score 1 or above. But aspirin, there's really no role for that. So always remember in your patients, if they're coming with aspirin, if you want to investigate, try to investigate why they are on aspirin. And most of the time, if your patients are elderly, probably they have certain degree of peripheral vascular disease, stroke, or ischemic heart disease. Anything else?
Now, do we do renal artery ultrasound?
In our office?
Yeah.
Yeah.
I mean, does he do it?
Yeah, it's good, but remember that ultrasound is body habitus dependent, right? So to cross the belly fat, especially in men, and try to image retroperitoneal area where the renal artery is not really easy task. So he can try to test it, and remember what we do, we check the velocity. And the velocity, if we think the velocity above 240 meters per second or something like that, indication for high grade, then you have to send your patient for CT scan. But ultrasound in general, especially in our population, it is body habitus dependent. And yes, just take that into consideration. But I don't think it's worth the shot. You can order that and feel how he'll be either he'll see it, or if he doesn't see it, in that case you have to use your clinical judgment if CT scan with contrast is needed or not. We like CT scan more than MRA because CT scan more higher spatial resolution. But if you think that either MRA or CT scan can be done for these patients, it's reasonable.
Okay. Now, does in your intra-aortic balloon pump cause type A dissections? Can they cause?
Unlikely, right? Because you have to put it below the subclavian artery, left subclavian, right?
Mm-hmm.
That's by definition is descending. But if you have a genius like Leishmanov, he may dissect the whole out of the thing. Anyway, you understand what I mean. If you have somebody who's aggressive but should not, the balloon aortic, the intra-aortic balloon pump is in the is in the descending aorta, should not cause type A dissection.
Okay.
Unless you insert the wire, and in that case, the dissection is not going to be as bad because probably is going to be retrograde dissection. So the antegrade flow will take care of that. It's at least my experience.
Okay.
Anything else anything else? I don't know, peripheral vascular disease is not really much stuff in it. Just remember that you don't have to be extremely aggressive with panic about stenosis in peripheral vascular disease. Medical management is the key, and always justify what you do on your note. Make sure that it does really make sense what decision we're making. I'm not going to send this patient because I don't feel that carotid artery stenosis is really symptomatic. You're covered. Nobody can. It's guidelines. They are guidelines, so nobody can come back and, hey, why did you do that? Why didn't you do that? As long as you justify what you have, and make sure that your patients are on optimal medical management, guideline-directed medical management, and if not, just make sure that you document why not. I cannot use lisinopril because we've used lisinopril in the past, and kidney function got worse, hyperkalemia. But always remember that even in chronic kidney disease, you can use these kind of medications as long as you're going to check for potassium level and kidney function down the road and adjust your medication according to that. And actually, they are very protective. So don't make sure that certain medications don't prevent your patient from being on certain medications because you're afraid something's going to happen. Always do intervention and the check, intervention and the check. And when you do stuff like that, you're not going to have issues. If you feel that your patient failed this medication, then change to different one.